to welcome another good friend and good friend of Nebraska Oncology Society back to our meeting. So Dr. Eric Sherman is a medical oncologist at Memorial Sloan Kettering Cancer Center. His areas of expertise are head and neck cancer and thyroid cancer. Dr. Sherman received his medical degree from Columbia University in New York. He later completed residency in internal medicine at Bellevue Hospital, NYU, followed by a clinical and research fellowship in medical oncology at Memorial Sloan Kettering Cancer Center, a fellowship in medicine and fellowship in general internal medicine at Joan and Sanford I. Weill Medical College of Cornell University. In addition to his clinical position at Memorial Sloan Kettering Cancer Center, he also currently serves as assistant professor at the College of Medicine at Cornell University, and he is the principal investigator on multiple studies in head and neck cancer. So Eric, we are thrilled to have you back.
There you go, Dr. Sherman.
Okay. Okay, everyone. I don't know if people can see me or not.
Yes, we can.
Okay. So, welcome, everyone. I definitely miss going to Nebraska. Bernie and I usually go to a really great steak dinner, and definitely much better than anything we have in our area, I will have to say. Let me get this. And can everyone see my slide?
Yes, Dr. Sherman.
Perfect. Okay, so I will start. So, thank you for having me come to speak again. My talk is on the head and neck cancer and review of what we had in ASCO 2020. Definitely in these times, everything's very unique, and definitely a disadvantage is when we have these studies, have ASCO, we don't really have that opportunity to really talk to the different investigators or presenters like we normally do. Sorry. These are my disclosures. And my outlines is usually I talk about everything in head and neck cancer, but my focus really takes to be more on head and neck squamous cell carcinoma, looking at what was presented in locally advanced disease and metastatic disease. A lot of interesting studies were presented. One study is one that you'll see we get a little more emotional about, of a little more anger of the problems, but you'll guess that one. But the big one will be when we talk about thyroid cancer, because the thyroid cancer studies actually are practice changing. And when I mean practice change, I don't mean practice changing in a year or a few months, but actually practice changing a month ago. So that part is going to be extremely important. So let's first start with head and neck cancer, locally advanced disease. So one of the more anticipated studies everyone was waiting for was ECOG 3311 that Robert Ferris presented. And this was looking at transoral robotic surgery resection and was really looking at then randomization afterwards to adjuvant therapy. This was in P16 positive or HPV newly diagnosed oropharyngeal tumors. Everyone received transoral surgery, followed by risk-adjusted postoperative therapy. There were basically 3 arms. Arm A were the people who had the best prognosis, negative margins, N0, N1 disease, no extracapsular extension. Everyone is stage 3, stage 4, just to put that out there. But this group is the one that really should by far always do the best. Arms B and C's where there's randomization, but this was a group that had close margins, so not positive, but less than 3 millimeters. 2 to 4 positive nodes, some extracapsular extension, but very small, or perineural invasion or left vascular invasion. And I do have to say that the neural invasion and left vascular invasion are probably not like major risk factors, although they do have some for recurrence. And then arm D is that group that had positive margins or extracapsular extension, where the standard has always been to give chemoradiation, but they've also added those with 5 or more positive nodes. I'm going to really say ahead of time so people understand that this is not comparable to chemoradiation studies, and that's because stage migration. When we compare a patient who's getting chemoradiation and we don't know the pathological staging, If we go and do pathologic staging, that will be upstage in most cases. So it's not a great comparison to compare a T2, N2A or N2B head and neck cancer after surgery to one that you're treating with chemo-RAS. So it is a different population, and actually by stage should do better. So this is like this study, and I hope everyone can see my my arrow. Arrow. The group that had low risk, T1 to T2 and 0 and 1 negative margins, they got observation alone. This is still stage 3, stage 4 disease, really stage 3. And I think the rationale for this is that there's been a lot of single institutional studies that really push that radiation alone was fine, not to give chemo with it, despite having no randomized studies to support that, and randomized studies ever even say differently. And big databases also saying that doing 2 modalities is better than 1 modality. The high risk, the Arm D, all those patients got chemo and radiation. This is pretty much what we do standardly for non-HPV positive disease. They included this with HPV positive, which was, I think, very reasonable. But neither of these are actually randomized studies. This is just watching, single arm studies. The only randomization included in this intermediate group, you're randomized to receive 60 gray versus 50 gray of radiation therapy, and then looked at 2-year progression-free survival. This is a gigantic study, and that, the question existed was in a subgroup of patients just going for a difference of 10 gray. And I think we can really sort of argue, is this something that was really worthwhile? Is this going to be a gigantic difference? When we look at the results, there are a few important things that come out of this. The first thing that does come that should be pointed out is this Arm A. Let's see if I could mark this okay. This arm, yeah, that's a really bad drawing. I know that. You can see that this arm should be the best. There is no question. This is the group with the smallest disease. There's no, and one thing you see is it's not better. Yes, it looks a little bit worse. It's all within an error of margin, but it's definitely not better. And it really brings into question, is single modality ever appropriate for stage 3, stage 4 head and neck cancer, HPV negative or HPV positive? It is only 37 patients, so it's a very small subgroup. So I do get on my soapbox about that, but at the same time, it is something that really suggests this should be looked at more, and no assumptions should be made on single modality, as that's actually is part of the guidelines. When you look at Arm B and Arm C, so 50 gray versus 60 gray, it really does look like there's no difference. It is not a really good non-inferiority study, but at least this is suggesting, hypothesis generating, that 50 gray versus 60 gray may look about the same. And as we would expect from Arm D, it does a little bit worse than everything else. Still actually quite good in general, but does do a little bit worse than everyone else. So in terms of the conclusion of this study, it says we can do these large studies with surgery, but only as long as surgery is the only option. And this is a real problem. At the same time the ECOG study was going on, RTOG/Energy was trying to do a study of surgery versus chemoradiation, and no one would go on that study, yet everyone was willing to do this one. And it sort of shows that people don't, that the surgeons really don't like doing this randomization with surgery versus no surgery. And a lot of the authors on this are people who are actually known not to do randomized studies or really that many clinical studies. So people are very happy to go forward if there's surgery itself. But this doesn't answer the real question of surgery versus chemo-RADs. There was that study we talked about last year, if people remember, of Orator, which does suggest that there is no difference. If anything, maybe surgery is slightly worse. But that was a very, very small study. And what we really need is a big study to look at this question. The next thing is that while PFS is comparable in post-op 50 gray versus 60 gray, and it looks about equal in the subgroup of patients, this was not a real non-inferiority study, so this is really hypothesis generating. And the real question is, do we care about this? Quality of life data was not presented. It was collected. And I think that's going to be the most important thing we're going to find out about this study is there a difference for a 10 grade difference? If there is, that is going to be a major thing that we know going down on 10 grade really does lead to better quality of life. If it doesn't, then the question is, is it even worth doing a bigger study? Why take the risk of having worse outcomes if you're not changing quality of life? But that data still has to be presented, but that's what we're really most interested in. The next thing is that Arm A, as I said, was treated with surgery alone. This should be the lowest risk group, and this looks possibly even worse than Arm B and C. And so this really sort of brings up that maybe patients with stage 3, stage 4 disease should not be getting surgery alone. And maybe it's the same thing with radiation alone, is that this really should bring in the question of single modality therapy for this group of patients. 2-year progression-free survival looks great, like really, really great in all these groups. Could this be patient selection? Could it be that TOR's approach is superior to chemoradiation if you have enough people? More likely, I think this is more of a stage migration issue. There's also the question that a lot of people who went on the study were then found out to be ineligible and were not included in the analysis, a lot more than you would normally expect. So this is something, though, that I think really does suggest that we need to look a lot more closely at this surgery versus chemoradiation question in much larger studies. And I hope that one day that actually will get done. The next thing is something that sounds maybe not so exciting, but it's actually a gigantic argument in the head and neck community. And that's looking at when we do concurrent chemoradiation, do we do high doses platinum every 3 weeks, or do we do weekly low doses platinum? About 2 years ago, 2 big studies came out, or phase 3 studies came out. One was in nasopharynx cancer done in China, looking at weekly cisplatin versus every 3 weeks. Outcomes in the nasopharynx group looked about the same. When they looked at toxicities, it looked like toxicities were worse, actually, in the weekly group than in the every 3 week group, at least for leukopenia and thrombocytopenia, while other things like weight loss, mucositis, and nausea and vomiting were about the same. At the same ASCO, a group from India actually presented this weekly versus every 3 weeks in head and neck squamous cell carcinomas. This was, while all people were eligible, almost everyone in the study was post-op, and patients were randomized. And here we started seeing this very big difference between local regional recurrence in the group that got 3 weeks to weekly, and 3 weeks looked a lot better. And based on this alone, I mean, this really sort of suggested that really maybe we should not be doing weekly at all. The big problem with the study is that weekly cisplatin was only given 30 milligrams per meter square, and most of us will really consider 40 milligrams per meter square as our true standard of care. So there was problems with this study, and also the nasopharynx study as well. So this ASCO, the Japanese Clinical Oncology Group presented their data, and this was in all post-op patients. So this was a single group. This was a very good setup. It was a randomization, high dose cisplatin, 100 milligrams per meter square every 3 weeks for 3 treatments. The weekly cisplatin was at 40 milligrams per meter square. You can argue that radiation should maybe be a 70 gray instead of 66 gray, but that is really quibbling about a small thing that I don't think we've really proven one way or another. So this was, and the people they looked at that were post-op were people who were positive margins or extracapsular extension. So this is exactly the right population to look at. The thing about this study, and this I'll bring and I'll show why this is important, is that the Data Safety Monitoring Committee recommended terminating the trial early. And the reasons for them doing it were good, but you can see this is where there are problems when you terminate something. So what they saw early on, so you can see that these are not large numbers at this point, that patients who, when you look at the overall survival, there is an advantage in the group that got weekly cisplatin. So there actually looks to be better outcomes in that weekly group than the cisplatin group. And because of this, though, that it can show that the one-sided P for non-inferiority was that low, they knew that this was not going to be a non-inferiority study, at least from the data they have. So they stopped this study early, saying this is not going to turn around. This really looks like, if anything, there's a benefit to weekly. I will say a big problem with this study is that when it was presented at RA as an abstract, they showed this data, and I guess we already started seeing patients who had been seen at other big academic centers where people had already told them that, based on what they read on this abstract, that weekly was a standard of care even before this presentation. And this is why we'll talk about in a second, why you never ever do that. I mean, you always got to see what the presentation looks like, because this really looked great. Local relapse-free survival, exact same thing, a benefit for the weekly arm. When you look at toxicity was worse in the every 3 weeks than the weekly. You see that dysphagia is better than weekly, nausea is better than weekly, hyponatremia maybe a little bit better maybe in renal impairment and hearing, but things that really sort of suggest that the weekly was not worse than every 3 weeks and probably looks a little bit better toxicity-wise. So right now, this should be saying, okay, this is great. Why do I have like any hesitancy with this study? Well, that was basically because of the characteristics. And I know you usually present this first before the results. In this case, I want to present it afterwards, because when you look at this, you look at what happens in the oropharynx group and in the hypopharynx group. You see that there are more people with oropharynx in the weekly cisplatin. This is a group that's going to do a lot better. HPV, these are HPV positive. This is a much better prognostic group. Hypopharynx is a much worse than everything else prognostic group. And here you see a higher number there. T stage as well. You have a lot more T stages. And when you do chemoradiation, this is probably one of the most important things. And this 10% differences that you're seeing, that alone can explain the differences that you're seeing between both arms. And this is sort of, when you do a big randomized study, the idea is either one of two things. Either you stratify and you make sure all these things are equal. And the more stratifications you do, the more numbers you need. So it's understandable that you don't stratify for every confounder. But if you're doing a big study, the belief is that at the end of the day, these things will equal out. When you stop a study early, you don't get, you can lose this, and there could be an imbalance early on. And I think that's what the case is, that there's a big imbalance going on, and that alone could explain the differences. The other study that came out at ASCO was this one from Musker, University of Maryland. And this also looked at the same question, but they did it a different way. They looked at the Serum Medicare database from 2004 to 2011, and looked at oropharynx, hypopharynx, and larynx, and this was in the definitive setting, not the post-op setting. When you look at this, the high dose cisplatin arm does better than the low dose. Here you're seeing now a survival benefit with a high dose. Radiation alone, not very good. Is there explanations for this? Yes, there could be a lot of confounders. So that's the one thing is that when you look at these type of data in large databases, the good thing is you have very, very high numbers, but the bad thing is that you can easily miss, have a difference just because you're more likely to select a good patient on a high dose. Now, it also could be the exact opposite, that, someone who has a closer stage 3, say, you believe that weekly is less toxic, you'll go that way. But there's these confounders that exist. When you look at the hazard ratios, what you see is that, hey, there's definitely a difference in the high dose versus low dose. The carboplatin arm also does a lot worse. But it really does sort of go back to the idea that maybe 3 weeks is much better than low dose. So what do we have for the conclusion of this? Well, we get, after having 2 phase 3 randomized studies showing inferiority by toxicity and efficacy with weekly cisplatin compared to 3 week, we now have a prospective randomized phase 3 study that is positive for weekly. All of these studies have their flaws. There's not one of these studies that's at all even close to being perfect. Further studies do need to be done, and actually Energy is setting up a study just asking this question of high dose versus weekly. The question exists is the enthusiasm for these studies. This is an important question. However, most of us are more interested in what the latest PD-1 combination or other target therapy combination that exists. But this is something, and this is a question that really we knew was a problem, 20, 30 years ago, and we should have asked that at that time. But hopefully, the Energy study will actually answer this question. Right now, if you ask our institution, we still believe that high dose every 3 weeks cisplatin is standard of care. This is easily something that's arguable, but with this new Japanese study that's out, before we actually dropped weekly completely, like we would never do weekly cisplatin. Now, this is now our second line. We're okay with doing it because now we understand there's a big gray area. The next study I'm going to present is a randomized phase 3 study of dysphagia optimized intense modulated radiation therapy versus standard IMRT in head and neck cancer. This is presented by Nutting from a group in England. We know that patient swallowing problems after chemoradiation for pharynx cancer is common. It is hypothesized that reducing the doses to the pharyngeal constrictor muscles would improve swallowing function. And so for the study, they looked at the volume of the superior and middle pharyngeal constrictor muscles or inferior PCM muscle outside the high dose clinical target volume, and they set it at a mandatory mean dose constraint of 50 gray or less than 50 gray. The primary outcome of this was looking at the difference in mean MD Anderson dysphagia inventory. This is a very well-established measurement. And they looked at the composite score at 12 months after treatment completion. There's multiple secondary outcomes looking at multiple quality of life, including tumor control and overall survival. It's important to know that it's not powered for these things. And we do want to know that if we're going to decrease the radiation fields, we want the same tumor control and overall survival. The sample size is only 102 to be able to tell the difference in the dysphagia inventory composite score. However, like I said, it's not going to be good enough to know about non-inferiority in terms of local control and overall survival. When you look at the composite score, you can see an improvement of 7.2. That is significant. So there is a difference or an improvement with the decrease in the radiation fields. So the conclusion from this is a change in IMRT fields can lead to improvement in swallowing function. Well, why is that important? Well, it's important because there's a lot of studies going on right now trying to decrease toxicity from treatment. And most of these studies are all going from, let's go from 70 gray to 60 gray, 60 gray to 50 gray, 70 gray to 30 gray. We try and cut down chemotherapy or cut down how much it is. And it could be doing something as simple as just changing the fields can lead to this improvement in quality of life. There's no difference in the clinical cancer outcomes as presented this study, but it was a small study and it was not able to improve that something was really non-inferior. But like I said, changing radiation fields can be as important as dose reduction. And maybe this is where we should be more heading towards. An important thing also is that a randomized study in radiation are very feasible. The group in England, this is their second big randomized study. The other one looking at IMRT versus 3D conformal radiation, where they showed that studies that we refuse to do in the United States, they were able to do and look at what these outcomes are. And a problem that always exists is that a lot of radiation oncologists and surgeons will make changes in the way they do treatment. And using their own personal prior experience to try to show good or better outcomes, but without any real prospective randomized data. And in medical oncology field, we really should not. We often are not able to do this because we have the FDA mandating what you do. And this really says that we should be maybe really mandating these type of changes, and people shouldn't be making changes just ad hoc, which I think happens way, way, way too often. Now, my next thing is going to be head and neck cancer metastatic. And I know it probably sounds a little judgmental with some of these other studies, but I think they were all actually like fairly still good studies. This is a study that, you know, it easily could be that at the end of this study, Merck will insist that I never speak again. This is Keynote 048, and this was originally presented last year, but it's a randomized study looking at pembrolizumab in first-line therapy. And in this one, they tried to look at what the final results were once you go to secondary line. But this was presented last year, 2019, and it's been since published in a journal, JNCI, or no, sorry, in Lancet Oncology. This is a randomized study in the first-line setting for metastatic head and neck cancer. People got either pembro alone, pembro plus chemo being platinum and 5-FU, or what was considered the standard of care, or was the standard of care at the time, extreme, which is platinum, 5-FU, and cetuximab. This was on all. This was in patients where stratified by PDL expression. And the study showed a benefit in terms of pembro monotherapy in both CPS score greater than 20 and CPS score greater than 1. The total population, while it looks good, was not clinically considered significant because of the multiple look. You can see right here that's already 6 primary outcomes in this study. Pembro plus chemo versus extreme looked like there was a benefit in all 3 arms. This is when the study came out, this is a very, very tricky study to read because you can see they only put the p-value in these 3 areas. The really sort of, the way they have it set up was that was the only areas you're supposed to be able to look at and was still a multi-look. But these other areas, they were able to look at after the second review. And they basically presented this as real, as final outcome data. There is no benefit in progression-free survival in any of the arms. And in a lot of ways, we can say that's expected. Why? You know, when we see immunotherapy, the real benefit is this subgroup of long-term benefit. So the PFS wasn't better, wasn't like totally surprised. But it actually ended up being a very big deal once the paper came out. And the reason why I say that is what was never presented at any of the presentations, although there was very much high suspicion, is whether there was a change in what their outcomes were. And when you look at the paper and it's hidden in the supplement section, which is really, I hate to say this, but almost on the scummy side, they basically changed the outcomes in the middle of the study, right around the 8th amendment. When in the beginning, this was supposed to be, PFS was the primary outcome, and they were not looking at CPS score, but they were looking at PDL1. And they just changed all this without really, making this very clear to anyone. And their primary outcome from the initial part was PFS, which actually came back non-significant. So what did they do? What they ended up doing with presenting data say, hey, maybe if PFS wasn't any benefit in the patients getting treatment, let's expand the period to look at how people do in with the second therapy. So they're looking at PFS from the time of randomization to the end of their second therapy of treatment. So treatment after the study treatment. And while this is probably an interesting group to really look at, to do it this way really brings in a lot of questions. What are their outcomes? Well, they show that now you can see some progression-free survival benefit because you look much, much further away with pembro alone in the CPS greater than 20, in the CPS greater than 1. It was the same thing with the pembro plus chemotherapy versus extreme. So now they're able to show a PFS benefit. Not a gigantic benefit, but a benefit which they did not have before. When you look at what people got afterwards, well, that's actually pretty interesting because in the extreme group, okay, only 16.7% ever got PD-1. And to me, that would have been what they should have been presenting, is if you look at the group that got PD-1 in the second line setting, did that group do just as well as when you get PD-1 in the first line? Because that's the question we don't know. And the study never answered that question. And here we can see that a big problem is that this was an international study that a lot of people just didn't get PD-1. it would have even been interesting to look at looking at this chemotherapy group in the second line, because that is something that we sort of wonder is, does chemotherapy do better after PD-1 than after like something like Extreme? But none of this data was presented. This was a study really presented to try to more justify the end results of Keynote 048. So I hate to say this is a really pointless and misleading study done to try to show a PFS benefit when the initial study did not. Data showing benefit after immunotherapy with chemo is not shown, and that we would have been interested in. Data showing how the subset of patients who received immunotherapy after Extreme was not shown. And it is noted that the initial protocol that only included PFS as a primary endpoint, and that was changed in the middle of the study, a definite no-no. And we still don't know that what does this subgroup of CPS 0 do, or does CPS 1 to 19. So I know this really, there's never a study that's ever been out that I've ever found to be this, I'd say, sleazy in how they presented it. And it is such an important study, and we don't know the real data with it. You would think that the one thing is clear, that the CPS greater than 20, there's no question there's the benefit with immunotherapy. But even that, we still don't know. Does it matter if you give immunotherapy first line, or can you just give it second line? And we don't even know that answer, with this study, even though they really do have this data. So I've never ever been like this upset about a study that as really should be a game changer. And it is something that, the FDA really didn't really force this out. They just approved all these drugs like in the first line setting without really looking at these questions. So this is really sort of, I think, a thing you always have to do with any of these studies. You have to look at them really, really careful. And there are a lot of ways to bring out positive results if you look far enough. And that's, I think, what was actually done with the study, is that they kept looking around, and they're finding whatever positive information they're putting out, like this is now what, justify standard of care of always giving PD-1 up front. And it really could be that, that's not what the case is. PD-1 in the second line could be good. It might be that, patients with CPS 0 should never get PD-1, that there's never a benefit for. And all these questions, we just don't know the answer to with it. So you really have to look beyond the conclusion. And the conclusion for this study was not really put there. Now, this is a study I love. This is a low-cost oral chemotherapy versus intravenous chemotherapy study done in India for recurrent metastatic head and neck cancer. Standard treatment is Extreme, Keynote 048, which we just talked about, or what the FDA always says is that everyone has to get cisplatin-based therapy. They drive everyone crazy saying, if you haven't got cisplatin-based therapy, you shouldn't be on almost anything until some of this Pembro data. The thing is that Pembro is, I can tell you, really expensive. Cetuximab, that's not a cheap drug either. These are really, really expensive drugs. And in low and middle income countries, they can't afford this. And if they're rare access to any of these agents, furthermore, even getting IV treatment may not be accessible for a lot of these people. So the question is there anything we can do in these cases? So there's a phase 2 study done at Tata Memorial Hospital. They looked at this combination of oral methotrexate plus celecoxib versus IV cisplatin, and it looked favorable to oral regimen. So they went right ahead and did a phase 3 study. And this is a nice phase 3 study, first line, IV cisplatin versus oral methotrexate and Celebrex, basically. So definitely like a good study that probably could never have been done in the United States. And what they showed was good outcomes. At first, that oral regimen, actually, guess what? That looks better than IV cisplatin. Really sort of says, like, why was IV cisplatin ever considered sort of a standard? And this, 7.5 months overall survival, it's not awful. It's not that great, I will admit. It's definitely not at all great, but it definitely gives an option for people who don't have access to either cetuximab or Pembro. Response rate, also not a bad combination for drugs you could give through the mouth. And this is a little bit similar to what we've already known, is that there were multiple studies done 30, 40 years ago, and these are old studies, where you can see single agent chemotherapy looking just as good as doing 2 drugs, with the exception that 2 drugs just give you a better response rate. And we can see with the study by Swag and Forster that methotrexate, when you look at the overall survival of single agent methotrexate, that looks as good as almost everything else out there. And so before cetuximab and before immunotherapy, this is, single agent methotrexate looks just as good as everything, with a lot less toxicity and also sometimes really a lot less cost. And maybe it was always a mistake for people to look at the extreme with 2 drugs plus cetuximab instead of just 1 drug. There was another study also, and this was more retrospective, looking at carbocetuximab in patients with metastatic disease. This was the idea that not everyone could get extreme, and honestly, most of us don't ever give extreme. That was a standard of care that, if you ask people to raise their hand even before Pembro, like who gave it, it was probably in that 5 to 10% range. It's a toxic regimen and not the easiest regimen to get. So they looked at like overall survival in this group of people. They had 103 patients, and these were patients with bad performance status, a good number of them, 40% PS2 to 3. And when you look at this combination of carbo and cetuximab, so no 5FU, much easier to take, you saw response rates of 39%. An overall survival of 7.2 months, reasonable, not as good as extreme, but if you look at the group closer to what you saw with extreme in the study, 10.1 months, you're actually approaching exactly what you might see with extreme. A median progression-free survival 3.7 months. And if you looked at skin toxicity as a good way of, as an early surrogate, you can see that the people who got skin toxicity really actually did very, very reasonable. There's also an older study done by HIT in Spain with cetuximab paclitaxel that showed an over 50% response rate. And these studies really questioned the need of platinum or cisplatin and extreme in showing good activity in patients receiving like single agent chemotherapy with or without a targeted therapy. And that maybe, we don't always need to get to like a 3-drug regimen, that a 2-drug regimen actually can work fairly well, and sometimes even going down to 1 drug. So now I'm going to talk about thyroid cancer. So anyone who was relaxed and playing with their iPhone before, this is time to pay attention. These are more of the game changers. And it's basically 2 studies I'm going to present, both of them very similar. The first one is Pralsetinib. This is basically looking at the clinical activity of the RET inhibitor Pralsetinib in patients with RET fusion solid tumors. And I'm really going to be focused on the RET fusion thyroid cancers. RET fusion genes are seen about 10 to 20% of papillary thyroid cancers. It is less frequent in more aggressive disease. RET mutations, while this study is not looking at, the next one I is going to look at it, are seen in about 50-60% of all medullary thyroid cancers when you combine somatic and germline mutant tumors together. Standard therapies that target RET, which are very important, Vindictinib, Cabozantinib, other things like Lenvatinib, have significant toxicities, and most of these are related that these are drugs that hit multiple targets, the main issue being VEGFR, and patients have a lot of trouble. Many of these studies will reduce their doses in close to 70% of their patients. So these are drugs that are difficult, even though they're all oral drugs. New drugs have been developed, and that's what we're going to talk about, that selectively target RET. Do they hit RET only? No. They hit RET with a little bit of there's still a little VEGF hit, and there is some minor VEGF effects, but nothing like we see with Vindictinib, Cabozantinib, Lenvatinib, etc. Using Pralsetinib, this RET-specific in RET fusion thyroid cancer, it's a small subgroup, these 11 patients, but the response rate is 91%. You just like sit back and go, wow. A response rate that high. One person has stable disease, which alone you could say is fairly good. And when you look at how long they last, They last for a long time. It's still very early on. We don't know what the true median progression-free survival is going to be with this group, but it really looks like these last long. I will say that the one with stable disease, when you don't last 4 months, probably that one patient was not even a stable disease. I wouldn't consider it stable, but at the same time, that doesn't make a big difference. This is something 10 out of 11 people are getting great activity from these drugs. And these drugs are very, very well tolerated, much, much better than anything else we have out there. Selpercatinib is the other one out there for RET altered, and he presented this, Manish Shah, in all RET altered thyroid cancer, so not just the RET fusion ones. And when you look at this in pre-treated medullary thyroid cancers, these are RET mutations, this is pretty amazing. I mean, 69% response rate, wow. However, that's not just that. There's a 9% complete response rate. This is just like really just amazing. And these are all pre-treated people. So these people got Vindictinib, Cabozantinib. When you look at this group of patients who had complete responses, most of those got both Vindictinib and Cabozantinib. This is truly like just, I hate to say it, just amazing what you're seeing with these two drugs. When you look at the group that had pre-treated follicular cells, so these are the RET fusion ones, just like what we presented just before, you see the same thing. An extremely large number of people having major responses to it. And here you're seeing patients with anaplastic and more with poorly differentiated thyroid cancer, and they're still like responding. So this is really impressive altogether. So let's look. So when you look at the data, 69% response rate in those who are pre-treated, 73% in those treatment naive. So these are unbelievably high responses in a fairly good number of patients. Median progression-free survival is not even reached in the pre-treated. In the treatment naive, it's 24 months. Longer follow-up already in the pre-treated. Fantastic 1-year progression-free survival, maybe slightly favoring the treatment naive. So first, this is unbelievably great data. The one thing it does sort of say though is look at the first line and second. I mean, look at it, treatment naive and pre-treated. This says these drugs work no matter what you're doing. So whether you got pre-treated or not, a real question exists is does it work the exact same in both populations? And the data is still not mature enough to say that. But this is something that may work just as well, whether it's first line, second line, third line, 12th line. So this is really impressive. When we look at the RET fusion genes, tumors, 79% response rate. I know the other one's 91%. These are two different studies. And yes, sometimes you have a difference that's so big, like let's say Lenvatinib versus Sorafenib in follicular cell thyroid cancer, that you say, yeah, there's no question one drug's better than the other. But these differences are not that. So this just shows that both are unbelievably active, not reach median progression-free survival, high progression-free survival rates. So really quite good. So the conclusion here is that these new RET inhibitors represent the new standard of care for RET altered thyroid cancer. Selpercatinib has now been FDA approved already for all lines of therapy. So, and this happened about 3 or 4 weeks ago, maybe 5 weeks. So this is not like what's coming around. This drug is already out there. Pralsetinib, it's going to get FDA approved pretty soon too. So this is drugs you need to use for any of these RET altered tumors. You need to know if the tumor's RET altered, and this is really impressive. There are still questions about the sequencing of treatment and mechanisms of resistance. So we don't know why the tumors eventually do grow. We need to figure that out. But the sequencing is going to be important. I have no idea that if I try to give Cabozantinib and Vindictinib after one of these two drugs, does it work in medullary? It might not. But let's say it doesn't work afterwards. And let's say these drugs work just the same in first or second line. Well, then it questions that despite the fact these drugs are much better tolerated, maybe we should be using these as second line drugs, not first line. These are things we don't know the answer to. Right now, the only thing we do know is that these should be our standard. So I would like to say is really thank you very much for having me here. It's an honor to talk about this. I will not be standing up, so you have no idea outside of my shirt and tie, whatever I'm wearing. But you know, it's a very, very different time. But it's a pleasure again to talk to everyone about this. So thank you very much.
Thank you, Dr.
Thanks, Eric.
Sherman.